we've been getting better and better at predicting who will do well with transplant. As I mentioned, it's now pretty clear that if patients fail to achieve a complete remission or a very good partial remission with their salvage therapy, they generally, unfortunately, don't do that great with typical autologous stem cell transplants. There is some data that potentially using some of the newer preparative regimens with transplant could overcome some of these resistant profiles. But in general, the thought is that we really have to get patients into at least a very good partial remission before going into transplant. And so that kind of brings up the next question: how many of those patients who we give salvage therapy will actually get to a decent remission and go to transplant? And data suggests that it's probably somewhere around 50%. Now that 50% includes patients who either were not healthy enough to get salvage therapy or were not able to achieve a remission. So this is a pretty big unmet need. About half the patients who relapse unfortunately will not go to a transplant, either because they're not healthy enough to get treatment or the transplant, or we can't get them into a remission. So this really brings up a goal of what a lot of us are doing in clinical practice and in academic research, is trying to identify regimens for this patient population, either regimens that are potentially less toxic than traditional salvage chemotherapy, autologous stem cell transplant, or regimens that will work in these patients who unfortunately are still great performance status, but the salvage regimens don't work. And that would mean trying to identify, for example, regimens that target different mutations, regimens that maybe use different drugs than we typically use to overcome these kind of unfortunately resistant profiles that can occur in patients in a relapse setting. If all goes well and patients achieve at least a good partial remission prior to transplant and then go on to transplant, the odds are that a significant portion of those patients will achieve a long remission. And what does that mean? Essentially a cure. About half of those patients who go on to autologous stem cell transplant after salvage will probably never relapse, and that's great news. But unfortunately, about half of patients still relapse. That means even though they achieve a remission, go on to a transplant, at some point after the transplant, that lymphoma comes back. And that is also, unfortunately, a huge unmet need. In the past, we would often treat those patients with things like allogeneic transplant. This would be a transplant from a donor instead of using their own cells. Many times we would expose them to other salvage regimens to try to control the tumor. Sometimes we use radiation to symptomatic areas, and many of those patients would go on to clinical trials, again, looking at or exploring regimens that potentially would exploit some novel mechanism in order to overcome some of the resistance that unfortunately led to relapse after transplant.